Recording in progress.
Thank you for joining us for tonight's educational webinar on neuromodulation. Tonight's speaker is Dr. Dustin Reynolds, OrthoNeuro Interventional Pain Management Specialist. Dr. Reynolds is a board-certified anesthesiologist specializing in interventional pain management. He has special interest in complex regional pain syndrome, neuromodulation and spinal cord stimulation, peripheral nerve stimulation, and other novel interventional pain management therapies. Please type questions in the Q&A box below, and Dr. Reynolds will answer your questions following his presentation. Dr. Reynolds?
Hello. Welcome. Heather, real quick, I'm getting a lot of feedback. Okay, never mind. There it goes. Well, hello. Thanks everyone for joining tonight. I'm going to try to keep it within an hour. Sometimes I can talk a little longer, but we're going to try to keep it tight here between 7 and 8 o'clock. I want to focus on some advanced therapies that we do offer in the interventional pain space, some non-surgical approaches to pain, minimally invasive therapies that can work for pain outside of other modalities or treatments that you may or may not have already been given. So with that, we're going to talk about neuromodulation tonight. Neuromodulation is stimulation therapy. Stimulation therapy has been around for a long time. Peripheral nerve stimulation therapy, spinal cord stimulation therapy, and dorsal root ganglion stimulation therapy. Now, the first two I mentioned, peripheral nerve stimulation therapy and spinal cord stimulation therapy, has been around since the late 60s and early 70s, so over 50 years now. But we've come a long, long way, and these devices are very, very advanced. Now, I want to focus on 3 different types of pain tonight, or 3 different diagnoses that are indications for these types of stimulators. Now, the first one, why a lot of you might be joining tonight, is for back pain or post-surgical back pain, spine pain. One of these diagnoses is something called post-laminectomy syndrome. It used to be called failed back syndrome, but now we use PLS, or post-laminectomy syndrome. Laminectomy is actually a procedure where you cut into the lamina. Maybe some of you have already had that procedure done, that can relieve compression on the spine or the neural elements of the spine. Now, these 2 different diagnoses, or different names for the same diagnosis, I should say, are characterized by these symptoms: persistent or worsening pain, numbness, possible tingling, radiating pain, and other symptoms after a spine surgery. Not just a laminectomy. It could be something like a fusion where hardware is involved, rods, screws, things of that nature. It could be a discectomy or other forms of surgical spine corrections. Causes of this type of pain for this diagnosis, this post-laminectomy syndrome: scar tissue that can form after the surgery, instability of the spine. Now, a lot of these times, these conditions, these surgeries, are due to degenerative causes, or the reason why we did the surgery in the first place. As we age, all of us will lose our height. That's why we shrink, because the disc, those little shock absorbers in between the vertebral bodies, lose their hydration, so they become more collapsed or compressed. Now, as those shrink and those bones get closer together, then that will start to put pressure or compress the spinal canal, the central structure going through the spine, all the way from the neck down to your tailbone, or the nerves where they're exiting outside that spinal canal. So all that compression. So when we say instability of the spine, you may have had a surgery that, yes, corrected that compression, but now because you changed that architecture of the spine, those bones, those vertebral bodies may become unstable, and they might start shifting forwards, backwards, maybe even side to side. So you might have to go back in there for another surgery and stabilize it. Another cause for this diagnosis, this post-laminectomy syndrome? Recurrent disc herniation. Now, like we said, those discs will degenerate over time. They'll lose their hydration. They'll become more collapsed, and they'll like to shift out of place. Now, that could be happening even without pain. If you took a poll or looked at the diagnostic imaging, say an MRI or a CT scan, of those the ages between 20 and 60, about 60 to 70% of the time, we would see a disc herniating or at least bulging out of place. That doesn't mean it necessarily has to cause pain, but it can in the future if it starts to hit some of those nerves or those nervous structures that I mentioned above. Other causes, nerve damage. Now, just because you have a surgery and you decompress those areas of the spine, that doesn't mean that the nerve damage hasn't already been done. Now, those nerves could be under pressure from an acute injury. Maybe you had that happen within the last month, or this could be something chronic in nature, developing over 3, 6, 5, 10 years. The farther that gets out, the more likely that nerve damage has already sunk in, and it may never return to 100%. Nerves are very finicky. It can be a slow and long healing process, but that does not mean that it will 100% regenerate to the time of normalcy. Another cause, just failure to achieve the desired outcome. Now, that doesn't mean a failure of the surgery, just sometimes your pain is not completely resolved. I'd say there's about an 85% success rate or something close to that. That's at least our own anecdotal evidence within OrthoNeuro with our spine surgeons. That's higher than the national average, which is a good thing. We have very skilled, talented surgeons in our practice. Pain after spine surgery across the country is usually around 70% or so. So you're not alone if you're still having pain after surgery. I want to reiterate the fact that does not mean the surgery failed. There just may be other causes to that pain that are listed above in that slide. That scar tissue, that instability, recurrent disc herniation, nerve damage. Those 4 things, probably the continued source of your pain. Now, these symptoms can vary, but like I had mentioned above, that can include persistent pain in your back or in your neck, buttocks, legs. You can feel that numbness, tingling, weakness into your lower extremities or even your upper extremities if you had a cervical spine surgery, something called an ACDF or an anterior cervical discectomy and fusion. You could have difficulty walking, standing, muscle spasms, fatigue. All of these symptoms can be included in that diagnosis of post-laminectomy syndrome. This diagnosis is diagnosed based on our physical exam, our interview process when you come into my clinic or other pain providers' clinic. We'll go over your medical history. You'll tell us your story. We'll also look at your MRI, your CT scan. Those are very important. Those 2 modalities of diagnostic imaging, MRI and CT scan, one being a magnet and one being computer-aided, X-ray almost guidance, but not actual X-ray. That is using radiation when you use a CT scan, but not an MRI. The X-ray will not show us those neural elements that I discussed. It will not show the nerves. It will not show the disc. It will not show the spinal canal. It will show alignment. It'll show arthritis. It'll show fractures, but MRIs or CT scans are needed. Now, we do need X-rays at times too, especially the surgeons when they're looking for those other features, those alignment, those fractures, and things that they're going to use for pre, during, or post-surgical evaluation. But MRI or CT scan, when we start to talk about these other structures that might get compressed, absolutely needed. Now, treatment options for this different pathology, this post-laminectomy syndrome. Now, just like you would go through conservative care even before a surgery for that pathology, those discs, those nerve compressions, that spinal canal stenosis, maybe that severe form of arthritis, we would try different medications. We call this multimodal management, meaning using different medications from different classes to target different receptors. Now, I'm not going to go into all those medications tonight. So just for time's sake, we're going to talk about pain relievers, anti-inflammatories, maybe even nerve blocks with local anesthetics, gabapentin, or what we call nerve pain medications, gabapentinoids, which also include Lyrica, pregabalin, SSNRIs, things like Cymbalta or duloxetine, amitriptyline, and the tricyclic medications. Once again, a lot of different medications to help with this pain pre or post-surgery. Physical therapy is another avenue for success that can re-strengthen the spine, show you different techniques that you can continue at home to take pressure off the spine and help for, continued pain. Things that we would definitely want you to continue utilizing, not just in those flare-up situations, but building, a very strong conservative management process just for yourself to continue throughout time. I think that's very important. Like I said, not just when you're having pain and not just in the immediate post-operative setting, not right after surgery, but continue through the rest of your life. Core strengthening is key. Not only building those strong tummy muscles, but also those back muscles to create almost a protective shell around the spine to stop the other degenerative processes from occurring. Other things we can do after we've kind of made it further down this algorithm, if we're starting up here with medications and physical therapy and that works well, we'll stop at that point. But if you're still having pain and it's affecting your quality of life and all of your activities of daily life, we'll keep progressing further down that algorithm. The next thing in that algorithm would be injections. You've probably had epidural steroid injections where we inject particulated or non-particulated steroid, a corticosteroid, not cortisone, but similar, same family, if you will, into that epidural space that can help relieve some of your pain. Maybe we're injecting some medications into the facet joints, those joints that become arthritic in the spine. Maybe we're doing some nerve blocks to help with some of the arthritis or axial spine pain or radiofrequency ablations. All of those modalities can be used in this algorithm. Once again, if those fail to give relief, then we need to think about other options. And this is when we're starting to get into our talk tonight, the neuromodulation. Surgery, possibly, still may be needed. Something called adjacent segment disease. If you've had surgery on one level, those other levels above or below that surgery are continuing to decline. They're continuing to degenerate. By having one surgery, by no means does that mean you are good for life and that you may not require another surgery. Adjacent segment, those other levels of the spine that may need surgery. But if no surgery indicated and your surgeon or multiple surgeons through second, third, fourth opinions have said, yep, we agree, no more surgery indicated, let's start talking about neuromodulation. Okay. So neuromodulation, once again, is using stimulation to help with your overall pain control. The prognosis after this post-laminectomy syndrome, can vary per patient. But if we've made it all the way to this neuromodulation, we're going to try it out. It is a good avenue for minimally invasive success. 90% of our patients that undergo neuromodulation through the OrthoNeuro side, or at least in my practice over the last 5 years, 90% have had over 70% relief sustained. And we'll get into why and what those devices look like, how they're used. So let's talk about spinal cord stimulation. What does that mean? It does sound like a very fancy term. But if you break it down, it's actually pretty easy. We're going to talk about something called gate control theory. Now, you have different nerve fibers in the body. Now, if we're looking at this spinal cord here, I don't really show the exact spinal cord. I show more of the spine. And if you look off to the right, that is a battery or an implantable pulse generator, an IPG. This is actually from the company Medtronic in one of their demonstrations. But that's what these electrodes and these stimulators would look like. Those stimulators, as you can see, are going underneath the bone, but more in the posterior portion. They're going in the epidural space, but targeting an area of the spinal cord called the dorsal columns. Now, if you look at this graph and this open gate and close gate, if you see that little lightning bolt, that indicates the stimulator, the electrical stimulus. We're going to provide that to those A beta fibers in those dorsal columns to provide a positive charge and help block the negative charge, which is that open gate, which you see above, those C fibers that are more in the anterior portion of the spinal cord. So it's literally closing a gate. You're providing a positive signal from the stimulator, and you already have these negative stimuli firing from those C fibers and your pain fibers. So when those two stimulus, a positive and a negative, hit each other or cross each other, they cancel each other out. So if you're looking at it like this, you got one firing, the other one firing, you're closing that gate on each other. So they're passing by each other like this, but when they hit, it'll help cancel or filter. I'm never going to say 100% pain relief. Remember, going back to our own anecdotal practice data, 90% get over 70% relief sustained from using this type of stimulation. Now, those electrodes that are in that dorsal column that you see on this page, they are thread up underneath the skin, behind the spinal cord, in the epidural space, outside the dorsal columns, not in the spinal cord, but behind them. They sit, if you look at my back here, about right here, mid-spine, mid-thoracic spine, usually at the thoracic level T7 or T8. It's kind of between your shoulder blades. Now, not only would we trial those devices there, we would implant those devices. But let's focus on the trial here real quick. The trial, it's not a medical trial. They've already been studied. There's mountains of research, and I'm not going to get into all those studies, but all of them are very, very favorable for this type of therapy. But the trial is a test. We just want to test these stimulators for 7 days on average. It can be less, it can be more. I usually carry it out for 7 days. So for 7 days, those electrodes will be underneath the skin in that space, sitting between the shoulder blades, right there, right next to each other. 2 of those leads. The leads have little electrodes on them, and let me show you what those look like. I'm going to try to get it as close to the screen as possible. So you can see those there. You can see it kind of looks like angel hair pasta or maybe a spaghetti noodle. But then as I get closer, you'll see the little metal fillings on those. Those are the actual electrodes that are delivering the impulses. So when they're sitting there, those electrodes are firing that stimuli, those impulses, towards the dorsal columns to provide that positive stimuli to block out the negative stimuli and your pain. So the best way to compare it, I just call it a noise canceling headphone system, or a pacemaker for your back, or a nerve blocker. But it's helping filter out all that electrical noise going up the spinal cord to the brain. Now, those electrodes will sit there underneath the skin, behind the spinal cord, and the tips, the end of that, for 1 week, will come out and attach to that battery, or a battery like that, that will just be taped on the outside of your skin for 1 week. So you'll go about your life, with very limited restrictions. I do call it the t-shirt test, kind of watching your bending, lifting, twisting activities for the week. Something that would keep a t-shirt tucked in would be acceptable. Some type of movement that would untuck a t-shirt would probably be too much movement for the week, because these are just temporary electrodes and they could move because we just tape that battery and the ending portion of the electrode to the skin. There's a little bit of glue on there as well and some thin strips, but they're not sutured. They're not anchored into place yet. So there is a risk of migration. You wear them for a week. We hope that you get that 70% relief of pain or more. You come back in the office, we remove the entire system, the electrodes and the battery, and we talk about it. If you're like, wow, that was life-changing, that improved my walking, my standing, even my sleep, all activities of daily life, and we want to move forward with a permanent implantation, then we'll set that up for you. What does a permanent implantation entail? Or what does the actual procedure entail, even for the trial? These are outpatient procedures. You come to one of our surgery centers, you go home that day. You're probably only there 2 hours on average. The trial, that 7-day test, when I do that procedure, you're awake. I just numb the skin with a little bit of lidocaine and we talk to each other. I test those electrodes when you are on the table, making sure we're covering your painful areas. That could be your back, that could be your legs, that could be your neck pain, your arm pain. Once again, going back to those symptoms from that post-laminectomy syndrome or the other diagnoses that I'll talk about here later. If it's covering that pain and it's successful, then great. Then we'll go to the implant. The implant, same procedure, but now we have to make little incisions where we can fit these little anchors that we can suture into place so those electrodes will not move. But we'll also build a little battery pocket right either above your belt line or right below your belt line, but kind of in your extra tissue back here around the upper buttocks. That's where that little pocket goes, and that's where that little battery goes. So I have these batteries in my hand from 3 of the companies that I use specifically. I work with every company on the market. Right now, there's 8, I believe, that can do it. Medtronic, Abbott, and Saluda are the 3 companies that I use most. Nevro is another company. Biotronic is another company. Boston Scientific, even Nalu, they all have batteries as well. I will use those for some patients that have, been referred to me for that exact system. But these 3 are the ones that I use the most, and I'll kind of go through them and why. But let's just look at the battery. Let's look at Abbott's first. So Abbott's, I always compare it to a Fig Newton. It's very small. We're kind of like the face of an Apple Watch. This is the battery that you would receive that would be implanted in that region, either right above the belt line or right below the belt line. This battery is good for about 10 years and does need to be recharged. It only needs to be recharged on average about once a month. How would you recharge that? Do you know those little circle pads that you can lay your phone on? Well, they'll give you one of those or similar to that inside a belt that you can wear, and that just sits on the outside of your skin against that area where the battery is, recharging that device. For Abbott and the Eterna, it takes about 2 hours, maybe 3 hours, but only once a month. The other 2 batteries, let's look at Medtronic. Medtronic, smallest on the market, slightly taller or has greater height, if you will, than the Eterna device. I'll compare here. But if you look, much thinner. But if you actually look at the internal dimensions, they're very, very similar. I think there's only like a 0.01 cc or milliliter difference. So volume-wise, they're about the same. But Medtronic is technically the smallest on the market right now. The last one, Saluda. Saluda is very interesting, though. Slightly larger. This is their current model, but they're about to get FDA approval in the next 12 months for one that's about 20 to 25% smaller. still slightly larger than the other ones, but they offer something called closed loop therapy. And this is where I'll kind of talk about some of the waveforms. So we talked about those stimuli, the spinal cord stimulator actually stimulating the dorsal columns of the spinal cord. But what waveform, what stimulus is being sent there? Now, Saluda uses something called paresthesia based or tonic stimulation, meaning it's a constant pulse at a set frequency or hertz level. That's typically between 40 and 60 hertz. Now, I'm not going to get into the energy and milliamps and all those other things for tonight's talk, but that pulse is continuous. It's tonic. It just keeps going. There's no change in it. It's the same all the time. But because Saluda offers something called closed loop, it's able to sense and stimulate at the same time from different portions of those electrodes. By doing that and set mechanisms from machine learning or AI learning and knowing what works for you and your body once we program that device, it can drop or increase that stimulus to keep a very tight therapeutic window. It's almost like we're dosing the spinal cord just like we would dose your medications. If we find that a dose is right for you, we want to keep that dose very, very close. We don't want it changing. Abbott does not have a closed loop system right now. They offer a waveform called burst. It's where there's successive pulses that are on and then they're off. So maybe a less chance of building tolerance in the spinal cord. On, usually about 5 quick pulses, then off. Then on and off. That has been shown to effectively reduce pain, but also it's been shown to reduce other things like catastrophizing, which we've seen by activating different pathways in the spinal cord or tracts of the spinal cord. That is something only Abbott has been able to show. Someone can correct me if I'm wrong on that, but from my study of the research, they are the only ones that have been able to show that currently due to that waveform, that burst waveform. Medtronic, now, they can do paresthesia-based, that tonic stimulation. They can also offer something called DTM, or differentiated targeted multiplex, which is very complex, and it's a different algorithm and where it senses and stimulates, but it's used to drive that stimulation to stop gene expression of inflammatory mediators. Inflammatory mediators are kind of like a chemical signaling that creates your pain. And at least rat models so far, Medtronic, with their waveform, has been able to show that. Now, they can use closed loop as well, but they're not in closed loop most of the time. They're only in closed loop about 10% of the time where they're sensing and stimulating. They almost use it like a governor or like a filter on your stimulus. So if you hit this action potential, this ECAP that we call it, they'll use that to back down the stimulation, maybe about 20, 30%, and run this waveform called DTM, but you won't feel it. That's the other thing I need to mention. The burst waveform with Abbott and the DTM waveform with Medtronic, you will not feel. It's almost like it's background white noise. Now, with Saluda and that closed loop, that tonic paresthesia-based waveform, you can feel it. Now, how strong is that? Depends on how high you go with the stimulus. Some patients want to feel it. Doesn't mean that if you don't feel it, it's not working. Some patients do have that concept, well, if I'm not feeling it, it's not working. That's not true. Still working in the background, even with these other waveforms that you're not feeling. But with Saluda and that closed loop, and if you are feeling it, it's the way I explain it, it's typically like if you feel your shirt, 99.9% of the day, you're not going to think about yourself wearing a shirt. You're not constantly thinking that, hey, I'm wearing a shirt right now. But if you sit there and you really put your mind to it and you think about it, it's like, oh yeah, I can feel my shirt touching me in those areas. That's almost like the paresthesia-based form. Some really enjoy that, some do not. But that's just my little diatribe on spinal cord stimulation, on the different batteries, on the different waveforms, and the ones that I currently use most. Those three companies, Abbott, Medtronic, and Saluda. So with that, continuing, you can use spinal cord stimulation therapy not only for that post-laminectomy syndrome pain or that pain after back surgery that we talked about. There's also other indications or diagnoses that are improved by your insurance. One of those being painful diabetic peripheral neuropathy. So if you are a diabetic and you have that burning, tingling, numbing pain that you can feel into your extremities, we're going to focus on the lower extremities. As you can see here, spinal cord stimulation therapy has only been studied and shown effective in painful diabetic peripheral neuropathy of the lower extremities, not of the upper extremities, not of the fingertips, more of your stocking or your feet level, then we could utilize this therapy. So if you have a history of poor glycemic control, pain in your feet or lower legs, stabbing, burning, progressively leading to numbing pain, this might be an option for you. Now, typically, that diabetes will have to be there at least 6 months or greater. Now, some studies show maybe less, maybe a little more, but this is very, very common. And let's get into that. I think I actually have I want to get to this slide. No, I must have cut that one out, but we'll go through it here. So let's look at the normal treatment, the average treatment, maybe from your endocrinologist or your primary care provider treating your diabetes. When we talk about painful neuropathy, which we explained on the last slide, typically patients will be prescribed some of these nerve pain medications. What are those nerve pain medications? Pregabalin, also known as Lyrica that we discussed, or gabapentin, also known as Neurontin. Tricyclic antidepressants. Those are the amitriptylines and nortriptylines. Or serotonin, norepinephrine reuptake inhibitors. SNRIs. I also mentioned those before. Duloxetine. You've probably seen commercials for all these medications. Duloxetine, also known as Cymbalta. But here's the thing. Only about 50% of the time are those effective, and 50% of the patients will discontinue the initial treatment within 3 months. The twofold reason of that is, one, the ineffectiveness of the treatment, but more often than not, and I can't give you an exact number, but I know it's very high. I don't even want to state the number now, but I know it's over 50%, cannot even tolerate those medications because they can cause significant sedation or tiredness, imbalance, confusion, forgetfulness. Those are things we need to be very careful, especially in our aging patient population. There's new studies coming out even on those medications for long-term chronic usage showing increases in dementia or the risk for dementia. So once again, we want to be very careful on those first-line medications that are out there now to treat this peripheral diabetic neuropathy. If you cannot tolerate those medications or they're ineffective, what's next? Well, if you've been through physical therapy, you've tried the medications, it's been 6 months, unfortunately, there's probably not that much out there. In my practice, I'm not going to prescribe you an opioid, as you see here in the bottom. I've never prescribed an opioid. I do not believe in prescribing that for the type of pain that I see. I'm not saying that all opioids are bad. You may be on those here tonight. I do believe that opioids should only be used in the acute post-operative surgical setting, maybe for the first week, possibly 2 weeks after surgery, cancer pain, and end-of-life care. Those are the 3 situations where I feel like opioids can be used, but every other diagnosis situation, I feel like we have enough therapies today and other modalities of care that should be used so we can fight back against this epidemic and pandemic of overprescribing opioid therapy. That's why I do procedures. That's why I use multimodal pain medications that are not opioids. That's why I prescribe a lot of physical therapy. But that's why I'm here talking to you about neuromodulation, because it can work for this type of pain without opioids. So that's a long way of saying if you've made it through this peripheral diabetic neuropathy treatment algorithm and you are not seeing the benefit, and that pain, that numbness, that burning, that tingling from your diabetes is affecting those lower extremities, I'd say let's do that 7-day trial with that spinal cord stimulator. It can work the same way. It can work very, very well. So going to the benefits of this specifically for diabetic peripheral neuropathy, and this is from 2 randomized studies that have been pooled, and you can see that below. This was presented from Medtronic. Patients with a spinal cord stimulator are 17 times more likely to experience significant pain relief compared to the conventional treatment. Those pain medications and nerve pain medications and other forms of treatment that you saw on the other page, 17 times more likely. And those patients have been followed for over 5 years. That's not just saying 1 year that you're going to get 17 times more likely a result. This is something that can be sustained, that can be continued. And that's great. What do we consider significant pain relief? At least 50% or greater. 86% of these patients that have received spinal cord stimulation therapy for at least 1 year are getting over 50% relief. 86%. So that's pretty close to what I told you, 90% that we see in our practice. Average reduction in pain, 53% at the 6-month mark. That's the average. That's Medtronic. That's not my results from my practice. But if you're getting over 50% relief, you're not using opioids, you're not taking other medications that are giving you really bad side effects, it's pretty fantastic. I mean, I know it's not perfect, but 50% can go a long way. Everyone's pain is different. 50% can mean a lot of different things to our patients. So this is just kind of going through the preoperative, intraoperative, and postoperative setting, concerns specifically for diabetics that are getting spinal cord stimulators. There's risk whenever we do any type of procedure, any type of treatment in our pain field or in surgery or anything in medicine. Those risks with spinal cord stimulation therapy across all diagnoses include pain, bleeding, nerve damage, headache. Sometimes you can even form a blood-filled pocket called a hematoma. That hematoma could potentially press on some of those nervous structures and cause paralysis if not treated immediately. The treatment for a hematoma, you should evacuate that hematoma surgically by one of our neurosurgical colleagues. So that's why we pay close attention as you're going through these trials if symptoms start to develop. But we give you a list of red flags to look for. It's not information you can sit on. You would have to call us right away if that starts to develop. But it's very, very rare. Less than 1% of the time, any of these risks can occur. A hematoma, I believe on average, is less than 0.6% of the time. And that doesn't even have to be, just from the procedure. You could develop a hematoma just by walking down the street without any type of procedure. It's just more likely, low risk, but still more likely to occur if you have some type of spine surgery or maybe a device like this. It's very low risk, but I'm always forward, open, and honest about these risks and their current data of how likely that could occur. So for diabetics, we want to watch out for your hemoglobin A1C. We want to keep that under 8. The lower that is, the less risk of infection after the implant. We want to look at your kidney disease, cardiovascular disease, other anesthetic considerations. Our anesthesiologists that are putting you to sleep for the permanent implant We do want to have these conversations. We want to make sure that it's even safe for you to undergo anesthesia. Sometimes it might not be, but most of the time we can figure out a way to make that very safe, but also make you comfortable and cause little pain for this procedure. But we absolutely need to look at the entire body and all organ systems. So just staying with me here in this preoperative column over here, we want to make sure that the skin still has, enough integrity. Skin changes as we age. It becomes very thin. Maybe it can tear. Once again, that could open a nidus for infection. We want to watch out for that. So we want to make sure wherever we're going to place these devices, that skin is, a proper setting for this procedure. We also want to make sure that there is not some infection already occurring. So let's say you had shingles, or if you had MRSA or MSSA, or a history of that. Those are things that we need to know. We would probably hold off on that. Make sure that you had already had been properly treated with antivirals or antibiotics, whatever, to limit that risk of infection. Because it's not only infection on the skin. We do not want to introduce that infection, that virus, that bacteria into the spine, because then it can travel and it can make things a lot worse. Once again, low risk, but still a risk. Intraoperative, we want to make sure if you're a diabetic, we keep your blood glucose levels under 180. So even if you're doing the trial with me, we will check your blood glucose level before we even roll back for that procedure. Why do we do this? Because the higher your blood glucose level is that day, the higher the risk of infection. You see this, this battery, just like I showed you, this Inceptive device, the battery from Medtronic. A lot of the times when we implant that, we will put it in this antimicrobial pouch to limit the risk of infection, especially if you're diabetic. That's just showing an example of that. That does help reduce pocketed infections where that battery is lying. So yeah, that's where we're at on peripheral diabetic neuropathy. Now, the third thing. Now, the third type of pain. So let's recap real quick. Post-laminectomy syndrome pain, or pain after surgery, one indication. Number 2, peripheral diabetic neuropathy. Number 3, complex regional pain syndrome. I'm going to go into details here, but the next stimulator we're going to talk about is a dorsal root ganglion stimulator. And I'll come back to this slide to show you, but let's talk about CRPS. Complex regional pain syndrome. It's a diagnosis of exclusion, meaning that every other diagnosis that could be available has been ruled out. And you have to fulfill very certain criteria. We call that Budapest criteria. And you can look at that here. There's 2 categories of it: signs and symptoms. Symptoms are what you tell me in the office, what you present with, and that comes from your mouth, the things that you are experiencing. Signs are what I see as a physician during my physical exam. So in order for you to fulfill Budapest criteria for this complex regional pain syndrome, or CRPS, you have to have at least 2 signs and 3 symptoms, okay? So let's see. Let's go through it. Sensory, vasomotor, pseudomotor, edema, or motor atrophic. So the sensory category, allodynia. Allodynia is a non-painful substance that causes pain to you. For example, for most patients, me just rubbing your arm or rubbing your foot should not cause pain. But those with CRPS, that light touch will cause pain in that area. A lot of patients will present with foot or ankle complex regional pain syndrome. That's what I probably see the most. And they will tell me that bed sheets or socks typically give them a lot of pain. Hyperalgesia. That is a heightened pain intensity from pinprick. Let's say we prick you with a pin somewhere on the body. That's going to cause pain. Doesn't matter who you are. But hyperalgesia is when that pain is out of proportion to the normal think that's an exaggerated response. That's a heightened response. So that's another category. Vasomotor, differences in your skin temperature. We run at a certain normal temperature. With complex regional pain syndrome, you'll see more than 1 degree increase or decrease. That can cause different skin colorations too on different sides of the body. Normally with CRPS, you'll see like a reddish or purplish hue, and that depends on what stage of the CRPS. Is that in the acute phase, when you have a lot of vasodilation happening? Maybe it's more warm coming to the surface. Maybe that's very red, or maybe now it's in the chronic phase that we call the cold phase, and that degree difference is 1 less or more, and now it's starting to get maybe more dark red, maybe more purple, blue. Very, very common with this diagnosis. Edema just swelling. You'll see a lot of swelling, or maybe asymmetric sweating in this area of affected limb. Usually, it's going to be the limbs, upper extremities, lower extremities. You can get it in the abdomen. That's more rare. Can be in both extremities. It can spread, but you will start to see these changes if you fulfill this criteria for the diagnosis. Last thing, 3 different ones that we'll typically see the most: decreased range of motion, decreased strength, and possibly some changes in the hair, skin, and nails. Those are those motor atrophic changes that we're seeing. So that's the criteria. That's the diagnosis. Let's talk about the dorsal root ganglion stimulator now. We're going to go back. So unlike the spinal cord stimulator, this one is much smaller. Let me give you some comparisons here. So instead of it being like the angel hair pasta, once again, here is the spinal cord stimulator. Now, here is a dorsal root ganglion stimulator. There's only 4 electrodes on this one, but this one's more like fishing line. It's a lot thinner. It's thinner because we need to place it in a different area. We're not putting it in the dorsal columns, the epidural space behind the dorsal columns. We're actually putting it beside something called the dorsal root ganglion. Now, this is that model here. This is the spine, and you'll see my cursor here, over the vertebral body or the large bones in your spine. The nerves, where they're exiting the spinal canal, they have this tortuous kind of structure coming out through the foramen. The foramen is the actual opening. This is the spinal nerve. This is the spinal root, and it's made up of different portions. But the dorsal root ganglion is this little ball-like structure, and that sits under this bony landmark called the pedicle. Let's go to a different example here. Here's one that looks a little bit better. So this is looking at the back of your spine. So if you feel down your spine, you'll feel those bones protruding, possibly. Those bones in the middle, those are called the spinous process. So that's just kind of giving you a landmark that you can think about as we talk about that. Now, as you branch out and go more lateral to that, you'll have the transverse process. And the pedicle is that little area here. It's kind of like where the joint is. You'll see it's marked by a P. But that yellow structure, that's the dorsal root ganglion. And you'll see that on the left here. That's that little ball. That is a first-order neuron. What is a first-order neuron? So let me get back to it here. The first-order neuron, let's just use this page. The first-order neuron, that's where pain information comes from the periphery first before it enters the spinal cord and goes to the brain. So why is the DRG important? If you have an injury more distal or further away from the dorsal root ganglion, let's kind of look at this blue section here. That injury is occurring down maybe in the foot, in the ankle, and it's traveling up a long nerve to reach this dorsal root ganglion before entering the dorsal horn in the spinal cord. This area is the spinal cord. This is the dorsal root ganglion. This is the spinal nerve coming down through here. Now, as that information is coming up, that spinal nerve up to the dorsal root ganglion, it starts firing at a very low threshold, but it becomes hyper excitable. It's kind of like a bell that's been wound up and it's constantly ringing over and over and over at this low chronic firing threshold. And it makes it easier for it to keep ringing over and over and over. So that signal is going up that nerve and reaching that dorsal root ganglion first. And it's coming time and time again. Now, that wouldn't happen if you had the injury more proximal or closer to the spinal cord than the dorsal root ganglion. That's all that number 2 is saying. We're going to focus on number 1, that peripheral injury, that complex regional pain syndrome signal or stimuli that's coming to the dorsal root ganglion first after years and years of hyperexcitability. Now, with that, let's go to this page. These fibers, as they're reaching that dorsal root ganglion and they're becoming so excited, in a negative way, they're increasing amino acid release, norepinephrine release. Remember, we talked about that vasodilation, that acute phase, neural peptide release, pro-inflammatory cytokines. All of these things are bad. Those are the signals that are telling your receptors, ouch, I'm hurting from that area over and over and over again. We want to shut that down. We want to put a filter on it. That's what the the dorsal root ganglion stimulator does. If we can put that fishing line with those electrodes right by that dorsal root ganglion, we can filter out that noise. And that's what this is going to show right here. So this is that neuronal response. So if we stimulate, instead of getting these constant neuronal responses, those nerve impulses that you'll see right here that are firing over and over again, we're going to get it to slow down. We're going to lessen that ringing of the bell. We're going to make it more uniform. So we are creating a filter mechanism, once again, canceling out that pain that's going to the brain. Now, how is this different than spinal cord stimulation therapy? Well, there's been a lot of studies that have been completed on it. I want to focus on this Kemmler study that showed the potential for neuromodulation to treat CRPS. This was done back in 1998, or 2000. I think that's when it was published. But the accurate study is actually from 2016. That's what was used in order to get DRG stimulation approved across the country. Now, a group of doctors got together, they used these devices, they did it for these diagnoses, and they came up with these results. 70% chance of being a high responder at 3 months and 1 year. I mean, that's pretty fantastic. 70% chance. That's better than the spinal cord stimulator response that we talked about. And that's what they proved in that study, that dorsal root ganglion stimulation therapy is better than spinal cord stimulation therapy for that complex regional pain syndrome. Now, not every patient can get a dorsal root ganglion stimulator. Doesn't mean that you have CRPS, you can automatically get that. You still need to go through the conventional treatment algorithm, try medications, try physical therapy, try maybe some nerve blocks, things that we'll do first that can help. But if not, then we'll start talking about dorsal root ganglion stimulation therapy. Doing a 7-day trial, then doing the implant. The implant and that whole process is very similar. You still come as an outpatient. We still talk about it. Over those 7 days, if you're a high responder, then we implant the battery. The battery looks very similar. That's the same one. Sorry, that is similar to the other batteries that I showed you earlier. But the thing with dorsal root ganglion stimulation therapy, the only company on the market right now that has this product is Abbott. They have the patent on it. I don't know when that will be changing, but they are currently the only ones that can do that type of stimulation on label, and they have a great product. And this is what their battery looks like. So similar process, looks very similar as well, in terms of the battery. Still has about the same battery life cycle that we talked about earlier. I think it's typically good somewhere around like 7 to 8 years, slightly less than 10. But the thing with these companies, they're so advanced, they're constantly working on new ones and trying to get the FDA to approve that. So they're only going to get better in time. But dorsal root ganglion stimulation therapy, used for the right purpose for this complex regional pain syndrome, sometimes even post-laminectomy syndrome, if it's only affecting a certain area of the body, is very, very effective. Now, for time's sake, we're going to move on to the last section here. This is for peripheral nerve stimulation therapy. Now, we've talked about 3 different diagnoses: post-laminectomy syndrome, complex regional pain syndrome, and peripheral diabetic neuropathy. Complex regional pain syndrome can also use one of these peripheral nerve stimulators. They're similar. The electrodes look the same. The battery currently, though, looks like this little therapy disc, this little circular structure down here. These are all external. These are not implanted inside the battery. Let me tell you why. Why? Because we're just not there yet in the field. We are actively working on those fully implantable systems. So this little therapy disc sits on the outside, but it delivers an impulse to the receiver, kind of this little dime-sized structure over here that you'll see in the system component section. And that fires the electrodes. So the electrodes attach to the receiver, and the battery or external pulse generator will deliver that impulse, firing it, and that can help limit that pain to peripheral nerves. Peripheral nerves are those smaller nerves away from the spinal cord, away from the dorsal root ganglion. Maybe you just have a very isolated nerve injury. Let's talk about different areas like that. So that could be, all over the body. This is just showing where these nerve stimulators can be implanted. So you could do it for the shoulder. You could do it for the neck, maybe occipital neuralgia. Maybe you're having, headaches that affect only the back of your head or the top of your head. Maybe you've had like a rotator cuff repair or an implant for your shoulder, but you're still having chronic shoulder pain after that surgery. Maybe you have a fusion from spine surgery and we cannot access the spine because of that hardware. So I can't do a dorsal root ganglion stimulator or a spinal cord stimulator. A peripheral nerve stimulator could be used. Where I use them the most are for the lower extremities though. Foot and ankle or the knee. The knee is, I'm not going to say complex, but there's different nerves that we can target to help with knee pain. Now, Medicare and other payers won't allow you to probably get one of these devices before a surgery unless you have a note from a surgeon stating that you are not a candidate for knee surgery. Maybe that's due to your other medical conditions. Maybe that's due to your weight. Maybe that's because you don't want surgery. That's the last thing on your list that you would ever want to do for your body. Possibly, with proper documentation, we could try one of these peripheral nerve stimulators and save you from a painful knee surgery. Or maybe you've already had a total knee replacement. 10 to 20% of the time, even with those total knee replacements, this is data from across the entire country, you will still have chronic knee pain. What are you supposed to do at that point? You have a new knee, if you will. The components, the hardware is in the proper alignment and place. What do you do for that pain? You've been through physical therapy. You've been through other injections. You've been through medications. I can place these stimulators. We can place them around those small nerves that feed the knee, that control that pain sensation going to the brain from the knee. They're typically genicular nerves. Those genicular nerves are fed by divisions of the femoral and sciatic nerve. So we can target those in different areas. It all depends on where exactly your pain is for the knee. Same for the foot. I can pick out different smaller nerves that control that pain sensation to the foot. Those are usually divisions of the femoral and sciatic nerve, more sciatic than femoral, but all things that we could talk about. So Nalu, great company. They've been on the market, I believe, about 9, not quite 10 years. They were actually just bought out from Boston Scientific. Boston Scientific is a great company. Looking forward to working with them as they move through this transition. But we're doing some exciting things in the space. You know, we really want to change perioperative care of medicine. We want to utilize less opioid pain medications. How can we do that? Well, we can place these little peripheral nerve stimulators next to the knee, next to the foot and ankle, next to the shoulder, even before your surgery. Fire those up, decrease your pain sensation after the surgery, requiring you not to utilize opioids, giving you more range of motion, greater activity so you can work through physical therapy more effectively, build less swelling, build less scar tissue, and overall just have a better quality of life because you're having less chronic pain. We can't always avoid it, but with devices like this, we have a chance to do that. So I'm going to continue working on that front, doing research, working with these companies, making new devices, but just giving options to our patients that didn't exist in the past. We live in a very exciting time in my field of pain medicine where we just have more available options that we can use, but more studies, more products need to be utilized. You know, we just need to keep working towards more effective solutions, but it's coming. All great things. This is just kind of going through the same average pain reduction from the peripheral nerve stimulators with Nalu. Different targets that we talked about. And that's it. So at this point in time, I'd like to take some of your questions.
Thank you, Dr. Reynolds. The first question is, if your pain is 60% better, can you get the stim implanted, or does it have to be 70% or higher?
It does not have to be 70%. That is my own thing that I like to see in my practice. 50% or higher is actually the indication to move forward with the implant. That's what insurances require. Once again, pain is a number, 50%. You know, 50% can mean a lot to people. 60% can mean a lot to people. We want to see functional score differences. We want to see, how is your sleep improved? Are you walking further? Are you standing longer? Those are things we look at. So it's a whole collection of the data that you give back to us for that trial before we go to the implant. But yes, 60% would be enough. 50% is something that we would have to have in black and white on paper to move forward that insurances want to see.
How do you pick the device?
So a lot of the times I'll talk about all 3 devices in the exam room with the patient. I have pamphlets and education. I will bring in the device representatives. I will set up phone conversations. I want patients to be well informed about all of these devices. I don't have a horse in the race. I work with all of these different companies. I teach cadaver labs. I do research. I talk to the key opinion leaders out there in the field. I want to stay at the forefront of neuromodulation and in this space just to provide the most relief. Not because I want to get paid or anything like that from, you know, these companies, which I am a consultant for Saluda, for Abbott, for Medtronic, not for Nalu, but that's just because I believe in their devices. I would do it for all of the companies, but I want to go off of my own data that I see in my practice. So I will let you choose your device. I'm never going to steer you in one way or the other. If you want to talk about all 3 and decide what's right for you, great. I would love to have that conversation. They're very different, and we can talk about those differences.
If I decide to try neuromodulation therapy, what kind of recovery and follow-up care should I expect? And can therapy be adjusted if my pain changes over time?
Great question. Yes. So it can absolutely be adjusted if your pain changes, which it can. Remember, as we age, everything is getting more and more compressed. One level, may have a new insult to it. Maybe you have a new disc herniation or a new nerve compression or a stenosis, something that wasn't being picked up before or wasn't causing you issues before. We can meet with the representative either in person and sometimes even remotely to reprogram the device to give you greater coverage of your pain or even a new pain. Now, sometimes you may still require surgery if it's too severe. The stimulator may not always cover that new pain. We can always do other things, maybe injections or try other forms of treatment as well outside of surgery. But a lot of the time, we can regain coverage and still give you effective pain control. Now, what to expect? Let's talk about the trial first. So we went through all those risks, very low risk. You can expect maybe a little bit of pain after just from the procedure itself. I usually say about 24 to 48 hours, you may have a little soreness. Even though I'm giving you a lot of numbing medication and a lot of lidocaine in that area where I'm placing the electrodes, once that wears off, you might be a little sore because I still have to go through muscle and tissue to get access to that epidural space, but it should be very, very tolerable. Something that a little bit of Tylenol, maybe the medications that have already been prescribed to you, or an ice pack as long as it's covered so it's not getting the bandaging or the device wet. Because remember, you have to do sponge baths only for those 7 days. Other than that, shouldn't expect much, in terms of pain. Should be very, very tolerable. Now, for the implant, remember, you will be asleep for it. It takes about 30 minutes. It's done as an outpatient. That might cause a little bit more pain, maybe for a week or so, because you're actually cutting through that tissue. You may receive a short dosing of pain medications from that implanting specialist. I typically don't do the implants myself. I typically work with one of our spine surgeons where they build a little pocket where the battery goes, and I place the electrodes. So we kind of work in tandem or in combination effort. But that spine surgeon could provide you a short course of pain medications if absolutely required. But I'd like to see you just get by on maybe some of those nerve pain medications, muscle relaxers, Tylenol, maybe an NSAID like Aleve, Advil, Motrin, ibuprofen, things like that. Trying to reduce the risk of addiction tolerance with opioids. Not saying, you're a bad person if you take those, but we just want to mitigate all risk and not use them if we do not have to. But that recovery from the implant, very quick. Usually have some restrictions for a couple weeks, but this is minimally invasive. I do not consider it a major surgery. It's more of just a procedure. We kind of want to watch your bending, lifting, twisting activities for about 4 to 6 weeks. But after that, you're off to the races. You're back to doing all those activities of daily life that you really enjoy.
Severe headaches and neck pain, along with gastroparesis, makes oral medication impossible. Can spinal stenosis compress nerves that influence symptoms of gastroparesis?
Yes, depends where exactly those nerves are being compressed. If that's more in the thoracic spine or dealing with spinal roots that are connected to the peristalsis or the actual movement of things through the digestive tract, then absolutely. So it all depends on your pathology and that compression, what level in the spinal canal. But to answer that question effectively, yes, it can definitely affect that.
I have severe long-term peripheral neuropathy, unknown etiology, and are on 3 different pain meds without total relief. Are any of these devices helpful?
Yes, spinal cord stimulation therapy. So that mononeuropathy, or if it's just one nerve, or polyneuropathy, those are things we can definitely discuss in the office. I would probably choose a spinal cord stimulator for you. That would probably give us the most coverage But if it's in a focal or very localized area, maybe we consider the dorsal root ganglion stimulator or a peripheral nerve stimulator. But all of these devices could be used for that diagnosis.
Is there anything available soon for thumb arthritis pain? Or what otherwise might you suggest?
I would talk with a hand specialist, one of our orthopedic colleagues in our practice. Probably not something that we would utilize a stimulator for at this point in time, unless there's a direct nerve injury or one of those other diagnoses we talked about earlier tonight. Just for arthritis of the hand, probably not an indication for one of these stimulators. But maybe an injection, maybe some physical therapy, maybe some medication, maybe even a surgery. All things that could be covered with our orthopedic colleagues in our practice.
Thank you, Dr. Reynolds. That was our last question.
Great. So thanks again, everyone, for joining here tonight. I love talking about stimulators. It's my favorite thing I do in my practice because of the results that we see. It provides effective long-term relief, sustained benefit. It avoids opioid care, or at least limits that if you're already on it, but is an effective alternative in our interventional pain space for minimally invasive care. So please come on in to OrthoNeuro. I'm here at any time. Would love to chat more with you about it. And thanks for joining tonight. I hope you guys have a great night.
Thank you. This concludes our 2025 webinar series. Our next webinar will be scheduled in February of 2026. Enjoy the rest of your evening. Good night.
Bye.